particularly for patients who present with diarrhea, the combination of CRP testing and stool calprotectin, if they're both negative, can give us 99.5% certainty that IBD is not present. So they're very useful non-invasive markers. Other useful non-invasive markers are full blood count, looking at the white cells, albumin. Obviously, we usually screen sort of for other fecal pathogens, as well as doing a stool sample for calprotectin. We'd look for celiac serology, thyroid function, all the other things that will go into the workup of a patient with chronic diarrhea. So calprotectin is a substance that's present in neutrophil cytoplasms, and it has a number of uses in the IBD world. First of all, as a sort of a screening test to differentiate between patients who probably have irritable bowel syndrome and patients who are more likely to have inflammatory bowel disease. There is still a little bit of the science to be worked out. We don't quite know what the correct cutoff level is yet. Most authorities would use a cutoff level of 50 nanograms as being a positive. Personally, I think it's a reasonable thing to use 100 as your cutoff, and anything between 50 and 100 to test again. The availability in general practice varies throughout the country. We're working on trying to get greater availability of it here in our local region, but certainly in the UK now there's a lot of pathways for the workup of patients with chronic diarrhea, which includes CRP and calprotectin, and they work very, very well, enabling the people in secondary care to prioritise the endoscopies and the appointments for people who are most likely to have IBD, and also enabling primary care colleagues to identify better the patients who have inflammatory bowel disease and to get on with treating that. So it's a very useful entity.